Good evening. My name's Rich. I'm one of the co-founders of BiteMedicine, and today marks the last in a pretty lengthy series on ECGs. Today we'll just be kind of wrapping up everything that we've covered so far in the form of some case-based learning and some multi-step single best answer questions. So just a reminder that not only do we run webinars, but you can also use our multi-step SBA question bank that you can access through app.bitemedicine.com, as well as an accompanying textbook for all the major topics that we cover. And this is a summary of the kind of ECGs series that we've covered so far. And I'd encourage all of you to go back onto our website, and you can view these previous sessions for free if you missed them, because as a sort of collective, they form a pretty good basis for what you need to know for being competent with ECGs. And if you like our platform and you want to upgrade to the premium, then you can use my unique discount code for 20% off. So that's Richard 2021. So aim of today, we'll keep it under an hour, and we'll be covering 3 cases. Okay, the first one is acute coronary syndrome. Okay, I'm not going to labor the point because I know we've previously done whole sessions on it before, but I just want to cover a couple of nitty-gritty details. Narrow complex tachycardia management in the kind of context of a particular case, and also atrioventricular block and pacing. As ever, we'll be using Mentimeter. So if you go to menti.com and you put in this code, which you can see on the screen now, 28148564, you'll be able to access the questions as I release them throughout the session. So I'll put the code in the chat as well. 28148564 for those who want to play along. So without further ado, we'll get straight into it. So Mr. Singh, a 66-year-old male who awakes in the middle of the night with central chest pain. He has never had pain like it and describes associated nausea, vomiting, and shortness of breath. He says that his left arm feels numb and he has jaw pain. He is taken to hospital by ambulance, and the pain settles within an hour of onset. He has a past medical history of type 2 diabetes and hypertension. So this is a pretty classical case of ACS, to be honest. I think I've seen quite a few patients come into ED and AMU with stories like this, and that past medical history particularly is quite classical. Looking at his observations then, he's tachycardic, hypotensive, a little bit hypoxic, and his temperature is 37.3. So my first question to you guys is this: which of the following would not be appropriate as part of the initial management for Mr. Singh? And I'll take us over to menti.com now. So our options are morphine, oxygen, glycerol trinitrate, GTN, aspirin 300 milligrams, and metoclopramide. I'll give you guys just a few more moments to answer. So which would not be appropriate for this gentleman? Okay. So let's see what you guys have gone for. Okay, interesting. And the correct answer is GTN. Okay, so let's return to the case and let's have a look at why that is. So we'll just work our ways down. So morphine or diamorphine, nice, yet you can happily use those as analgesia for acute coronary syndrome. Oxygen is incorrect, and this is a common thing that they might test you on in the exam. Oxygen is a drug, and you can only give it when it's indicated. If the patient's saturations are 94% or more, you wouldn't give it. In this case, his saturations were 93%, so it would be appropriate. Next up, we have GTN. Now, some of you may know the phrase MONA, M-O-N-A, which is morphine, oxygen, nitrates, and aspirin. GTN makes up the nitrate component of MONA. However, and this is really important, and this is kind of the top decile stuff, you should avoid it if the patient is hypotensive. Its mechanism of action is to dilate the coronary vessels and promote blood flow to the ischemic areas. However, if the patient's got a blood pressure of 87 systolic, which is what they did, you would probably not give it in that context until you got the blood pressure up. So that was the purpose of this question, trying to catch you out there. Aspirin 300 milligrams, absolutely, you would give it as part of the antiplatelet treatment. And metoclopramide, so in this case, this patient had nausea and vomiting, and it would be appropriate to consider an antiemetic. And NICE recommend that metoclopramide is a good example that you can use. So this is a good question to watch out for in your exams, guys. Okay, so next up, I've got an ECG for you guys to take a look at, but I'll put the question here first. So the question says, given Mr. Singh's presentation and the ECG findings, which I'm about to show you, which of the following is the likely diagnosis? And we've got 5 different types of STEMI. So I'm just going to set up the next question on Menti, and then I will share the ECG. So this is the ECG. You also, very fortunately, get given some troponins. So the troponins are 32,000, and then a repeat troponin comes out as more than 50,000. They want to know what type of STEMI is this. Your options are anterior, lateral, inferior, posterior, or infero-posterior. I'll just leave that ECG up on the screen. It's not the highest quality ECG. I do apologize, but hopefully if you guys have got this on a fairly wide screen, you'll be able to see. Obviously V4, V5, and V6 are missing. Okay, so we've had 12, yeah, they're still coming, fantastic. All right, let's see what you guys have gone for. Ooh, fantastic, okay. Really, really good to see this. Okay, so we've got some sort of split between infero-posterior and inferior. I'm delighted this time that the majority wins. It is an infero-posterior STEMI. So let's have a little look at what's going on here. So in terms of the answers, and these are included in your slides that you can look at after, if we go into infero-posterior STEMI, there is on this ECG, ST elevation in leads 2, 3, and AVF, which would suggest an inferior STEMI. But there's also ST depression in leads V1, 2, and 3, which could mean there is a potential posterior STEMI. So let's just look at that one more time. We've got some nice evidence of ST elevation in leads 2, a little bit in lead 3, but definitely present there in AVF. There's some ST elevation in the contiguous leads of the inferior territory. And looking here in V1, 2, and 3, you've got a lovely demonstration of ST depression. So this is a recap from the ACS session. So this is a normal PQRST on an ECG. And what we mean when we say STEMI, or ST elevation myocardial infarction, is that the ST segment of the ECG is elevated above the isoelectric line, okay? Now, wherever you see that ST elevation, it gives you a good clue as to which territory of the heart is infarcted. For NSTEMIs, we tend to see ST depression or T-wave inversion. So we call these as ischemic changes. But let's say you saw these in the anterior leads, so V1 or V1 to 4 roughly. That would not necessarily tell you that this is an anterior infarct. So NSTEMIs cannot be localized very well on an ECG. So that's something important to remember. So just looking at this in a little bit more detail. So we've got leads 2, 3, and AVF correspond to the inferior portion of the heart, which is supplied by the right coronary. V5, V6, 1 and AVL is the lateral portion, and that's supplied by left circumflex in most people. And then we've got our anteroseptal / anterolateral, which is supplied by the left anterior descending, or LAD. So what's going on with a posterior STEMI then? So again, I've put these where you would see ST elevation in STEMI infarcts of the particular territories of the heart. So if you had a anterior septal infarct, you would see ST elevation in V1 to 4. But there's also this concept of reciprocal change, okay? So if you have a lateral STEMI, so ST elevation in V5, V6, 1 and AVL, quite often you see what is called reciprocal change. So you see ST depression in the inferior leads. Okay, you tend not to get reciprocal changes with your septal and your anteroseptal regions, but you do with a lateral STEMI. You get reciprocal changes in 2, 3, and AVF. And vice versa, in an inferior STEMI, so ST elevation in leads 2, 3, and AVF, you get ST depression in AVL and lead 1. So essentially, lateral and inferior, you get the opposite. With a posterior STEMI, a 12-lead ECG cannot detect ST elevation in the posterior portion of the heart because there are no posterior leads made up in a 12-lead ECG. But what a 12-lead ECG can pick up, if you're having a posterior STEMI, is the reciprocal change. So the ST depression that arises in a posterior STEMI. That ST depression tends to be seen in leads V1, V2, V3, and V4. So what I'd like to do is slightly amend the slide that I previously showed you and just say that if you ever see ST depression in the anterior leads, then it's one of two things likely. One, it's a posterior STEMI, and so actually you've got some ST elevation occurring in the posterior leads, but you just can't see it on a 12-lead ECG. Or it is true sort of ischemic change secondary to an N STEMI. Does anybody know, just looking at the chat function, how you would go about potentially trying to distinguish between a posterior STEMI and an N STEMI if you had ST depression in the anterior leads? See if anyone wants to suggest anything. Fantastic. Yes, I'm seeing it here. So posterior leads, extra ECG leads V7, V8, and V9. Exactly. So you basically just follow your way around the chest. You know, we normally have V1, just tilt my camera, V1 all the way down to V6. V7, 8, 9 sort of curves around the side of the chest wall and towards the back, and that's where you'll pick up your posterior STEMI. So that's exactly what they do with Mr. Singh. He has, you know, his pain is settled with a bit of morphine and aspirin, and they put on leads V7, V8, and V9, and that does show some ST elevation, suggesting that he does have a posterior STEMI. So my final question for this portion of the webinar, linked to this case, is which of the following coronary arteries is most likely to be affected in a posterior STEMI? And I'll get your options up on Menti. So which of the following coronary arteries is most likely to be affected in a posterior STEMI? Left anterior descending, left circumflex, posterior descending branch of the right coronary artery, the posterior descending branch of the left circumflex, or the posterior descending branches of both right coronary and left circumflex. Okay, let's see, you guys are voting. Okay, bit of a split picture. I think the majority definitely are going with it's some sort of posterior descending branch. The correct answer is the posterior descending branch from the right coronary artery. So let's have a little look why this is important. So LAD, we all know, supplies the anterior portion of the heart and left circumflex, the lateral portion. And I would hope we'd also know that the RCA tends to be the inferior portion. Now, coronary anatomy is not universally the same, okay? It differs from sort of different people. So some people we describe as being right dominant, some as left dominant. In those who are right dominant, their posterior descending artery comes off the right coronary artery. And we see that in about 70% of people. So given Mr. Singh, if we just assumed he is, like everybody else, we have to go with the majority and say he's more than likely to be right dominant, and therefore his posterior descending artery, which is responsible for his posterior STEMI, is coming off the right coronary artery. At 10% of people, they're left dominant, so the PD branch comes off the left circumflex. And about 20% of people, you get posterior descending arteries coming off both left circumflex and right coronary. So that's just a little bit of additional detail on ACS that I think you can kind of add into your notes that were already made probably very well from Schwabe's previous session on ACS. And just one last sort of final bit to cover is just a reminder of how you would then manage Mr. Singh's STEMI. So STEMI is diagnosed, we've given aspirin. It's a case of working out when his symptoms came on and is PCI available within 2 hours. So he woke up with his pain suddenly, 6 hours passed in ED, he's still in the window for having emergency PCI, or primary PCI. So you give a second antiplatelet like prasugrel or clopidogrel if they're taking any sort of anticoagulant like warfarin or rivaroxaban. You can also give unfractionated heparin, drugs like abciximab and bivalirudin, and then get them to the PCI center. If they're outside that window, then you go for the fibrinolysis route, start them on a second antiplatelet like ticagrelor, and then depending on symptoms and outcome, would get them for PCI. So that's a brief coverage of ACS, and I'd like to swiftly move on to the next case. So, next case is a doctor. Doctors get ill too. So Dr. McLean is a 24-year-old FY1 doctor who is admitted to the emergency department with palpitations. She said that her heart suddenly began racing this morning. She reports a month's history of occasional episodes of intermittent self-resolving palpitations and shortness of breath. She's otherwise fit and well, and here are her observations. So quite profoundly tachycardic. She's maintaining an okay blood pressure, but we want to watch, and all other observations are doing okay. And this is her ECG. So take a little look at what's going on here. Just while you do, get the next question moved up on Menti. So the question is, which of the following is an adverse feature that would warrant synchronized DC cardioversion in this patient? Okay, the options should be available on Menti now. So which of the following is an adverse feature that would warrant synchronized DC cardioversion in this patient? And our options are peripheral edema, raised JVP, systolic blood pressure of 95 millimeters of mercury, burning non-exertional epigastric pain, T-wave inversion in AVR, and V1. We've got a few more moments. Okay, let's see what everyone said. Okay, so seems to be a split between raised JVP and systolic blood pressure, with raised JVP getting just one more vote. Well done to the majority. Yes, raised JVP. So in this question, what it's essentially testing is, do you know what the adverse features are in anybody with a peri-arrest tachycardia rhythm? So working our way down the list, peripheral edema. So acute heart failure is one of the adverse features that would warrant synchronized DC cardioversions, but peripheral edema itself does not qualify for that. If you have pulmonary edema, however, flash pulmonary edema, then you could definitely argue that this is acute heart failure and would warrant synchronized DC cardioversion. Raised JVP in this context does suggest heart failure and therefore would be an adverse feature if present. Systolic blood pressure, so they say shock is one of the adverse features, but they define it as a systolic blood pressure of less than 90. So a 95 would actually be acceptable. Non-exertional burning epigastric pain on its own wouldn't class as an adverse feature. It more sounds like dyspepsia. But if you had a more classical cardiac sounding picture, that might indicate myocardial ischemia, which is one of the adverse features. So if it was a classic sort of presentation of central crushing chest pain radiating to jaw and left arm, then yes, absolutely, I think you'd be a lot more worried. And these T-wave inversions, they're very, they're very non-specific, and on its own, you wouldn't be concerned. So tachyarrhythmias, the most important thing you need to do if you're called ever to see a patient with a heart rate of more than 100 is, first of all, check that they've actually got a pulse, okay? Because when you were bleeped about it, they might have had a pulse, but by the time you get to the patient, they might have actually transitioned from peri-arrest to an arrest. If there's no pulse, put out 2222, get the crash team there. We don't have time to discover exactly how you would manage it in this lecture. Step 2, if they've got a pulse, however, you need to look for these adverse features that we've talked about: myocardial ischemia, shock, heart failure, and also syncope. Any of those present, you would want to consider synchronized DC cardioversion, and you can give up to 3 shocks. After which, you should start amiodarone 300 milligrams IV over 20 to 30 minutes. So that's adverse features in tachyarrhythmias. However, that's not what we're dealing with in this case. So there are no adverse features in Dr. McLean. So what is your immediate management given the ECG that was shown? The options are adenosine 6 milligrams once only, adenosine 6 milligrams followed by a further 6 milligrams adenosine if no effect, adenosine 6 milligrams followed by up to 1 more 12 milligram adenosine dose if no effect, adenosine 6 milligrams by up to 2 more 12 milligram adenosine dose if no effect, or vagal maneuvers. Bit of a mouthful, that one. Okay, let's see what you guys have gone for. Fantastic. Yeah, vagal maneuvers, well done. So you guys clearly know your tachyarrhythmia protocol. That's fantastic. So yeah, the first thing to do is to start with vagal maneuvers. Don't jump straight to the drugs. And sticking with this then, so despite vagal maneuvers, Dr. McLean's ECG remains unchanged. What is the most appropriate next step? So our options for those that can't see: adenosine 6 milligrams IV rapid bolus, adenosine 12 milligrams IV rapid bolus, amiodarone 300 milligrams IV over 20 minutes, adenosine 6 milligrams IV over 20 minutes, or atropine 500 micrograms IV rapid bolus. Okay, let's see. Ooh, so it's a split. So you're all very confident that this is adenosine 6 milligrams, just not sure about the timing. Okay, so majority wins once again. Can everybody hear me? Sorry, guys, I seem to have lost. Can everybody hear me? If you just check the chat function. Yep. Okay. Good. That's false alarm. Fantastic. Yeah. So for those who weren't quite sure about this one, the purpose of giving this adenosine is twofold. Okay, and it needs to be given as a rapid bolus. Firstly, when you give it, okay, you're going to give it very quickly because you want to lower the heart rate quite quickly. In doing so, that might actually cardiovert the patient and knock them back into a sinus rhythm. Because this patient clearly is not in a sinus rhythm. They have a narrow complex tachycardia that has no sort of evidence of clear P waves. The other thing to do is you might not actually successfully cardiovert them, but you might slow the rate down transiently enough to actually spot the electrical pattern of what's going wrong. So you might, for example, if you slow it down, be like, oh, I can see flutter waves. That must be atrial flutter. And that will, that will guide you in your kind of more definitive management. So it can be very useful. So yeah, you want to give it as a rapid bolus. You also want to warn the patient that they're going to feel like death because it's a very unpleasant experience to receive adenosine. So some people describe it as a feeling of impending doom. But I think just to warn the patient that it's unpleasant, but it won't, it won't stay. It's only a transient response they're going to have. So on to the next question. If a single dose of 6 milligram IV adenosine does not cardiovert the patient, what is the next step? We've got adenosine 6 milligrams once only, adenosine 12 milligrams once more only, adenosine 6 followed by a further 12 if no effect, adenosine 12 followed by a further 12 if no effect, or synchronized DC cardioversion. Okay, some subtle differences between each of these. The patient so far has had vagal maneuvers that were unsuccessful and a single dose of 6 milligrams IV adenosine. We're asking, what is the next step? Let's see where you guys are voting. Oh, love it. All right, anyone care to put one more vote in, see if we can tip it either way, or we're going to stick with 6 and 6? Okay, we're going for a complete matching. Here we go. So the winning team is the 12 and 12, okay? So the correct protocol is 6, followed by 12 if no effect, followed by a further 12. So 6, 12, 12. So let's return to our PowerPoint and let's have a bit of a catch up on narrow complex tachyarrhythmias. So main causes of a narrow complex tachycardia are sinus tachycardia. Okay, it's the most common cause that you will see, usually be driven by pain, infection, anxiety, pulmonary embolisms. But sinus tachycardia on its own is not pathological, so you don't need to treat it. However, the other causes are pathological, so it's atrial flutter with a regular AV conduction, AVNRT, okay, atrioventricular nodal reentry tachycardias, and AVRT, atrioventricular reentry tachycardias. And these were discussed in detail in a previous tachyarrhythmia session. But you manage them all the same in the acute setting, okay? So firstly, look for adverse features. Then it's vagal maneuvers. Now, what do we mean by vagal maneuvers? Well, it can be a carotid massage, so essentially stimulating the baroreceptors in your carotid arteries, or inducing a Valsalva maneuver that also promotes a vagal response to slow the heart down. And the best way to do that is to give them a sort of slightly pulled out syringe and get them to blow in it to try and push the plunger out as far as they can. And in doing so, they kind of set off their Valsalva maneuver. If that doesn't work, adenosine 6 followed by up to 2 more doses of adenosine 12. Now, as I've said, adenosine might not fix the problem. If it does fix it, it is more likely that it was an AVNRT or an AVRT, okay? If you don't get a response, you're thinking actually this could probably be atrial flutter. Because atrial flutter or AVNRT and AVRT tend to respond to these measures, okay? You tend not to get to the end of this protocol, which is useful in itself for the kind of diagnostic purposes. So Dr. McLean fortunately responds well to adenosine and she cardioverts, but she's kept in AMU, so that's the acute medical unit, overnight for observations. And in the following morning, she has a repeat ECG performed, which shows this rhythm. I'm going to leave this on the screen for a little bit, just to get you guys to have a really good look at it. There'll be a question to follow. Okay. We can return back if people need it. But so the next question is, given the likely pre-excitation syndrome that you just saw on that ECG, what type of narrow complex regular tachycardia had likely occurred on her admission? Okay. Bit of a wordy one. So, given the likely pre-excitation syndrome, what type of narrow complex regular tachycardia had likely occurred on admission? Options are atrial fibrillation, atrial flutter, atrial tachycardia, AVRT, or AVNRT. Okay. This is taking the concepts that were covered in ECG part 2 and taking them a little bit further this time. Let's see what you guys think. Okay, so we've got a good range, but the majority are leaning towards atrioventricular re-entry tachycardia, which I'm pleased to say is the correct answer. So well done. So let's have a little look at why this is. So the ECG showed classical features of Wolff-Parkinson-White, WPW, and we'll cover it a little bit more in a second. The most likely tachycardia or pathological tachycardia to occur with someone with Wolff-Parkinson-White is AVRT, okay? AVRT. The broad way to distinguish between AVRT and AVNRT in terms of its causes, AVRT arises due to an additional structural pathway that links the atria to the ventricles, so essentially some sort of accessory pathway, which is one of the key features of Wolff-Parkinson-White. Whereas in AVNRT, it tends to be an issue with your AV node, where you end up getting a circus rhythm formed. It's usually more of a functional issue, can arise due to problems with electrolytes, can also be due to ischemic damage, but it's AVRT that is the one that's most classically associated with Wolff-Parkinson-White. So before we cover Wolff-Parkinson-White, I've got one more question for you guys, which is, which of the following is not an ECG feature of a person with Wolff-Parkinson-White during sinus rhythm? Okay. All right, so clear majority. Oh, hang on, we've got a couple more votes for QRS duration of more than 110 milliseconds, but the majority are going for PR depression. Fantastic. Yes, well done. PR depression is the odd one out here. PR depression is a classic feature of pericarditis, whereas all of the other features listed are associated with Wolff-Parkinson-White. So you get this slurring of the initial part of the QRS complex, which is called a delta wave. And that's due to the fact that your accessory pathway or your ectopic pathway is inserting not equally into both ventricles, it's inserting to one side over the other. So you get kind of this initial depolarization and then the wave spreads, and you see that spread as a delta wave. You get this thing known as a pseudo-infarction pattern, so prominent R waves in V1 to 3, which is seen in around 70% of patients. A PR interval is short, and that's because your accessory pathway is faster than your intrinsic AV conduction pathway. So the P to the R points is much shorter because the conduction gets there faster. And your QRS sort of complex is sort of widened, not over the top widened, but just partially widened because of where that accessory pathway is inserting. It's not equal, so your ventricles are just depolarizing for longer, hence why that electrical activity seems to be going on for longer. So a quick overview of Wolff-Parkinson-White. It is a pre-excitation syndrome that arises due to an additional accessory atrioventricular pathway, just another way for the atria to talk to the ventricles. But the key point of it is that the pathway conducts impulses faster than the intrinsic conduction that we have. And it poses issues as it predisposes to a number of tachycardias. The most common one is AVRT, but it can cause other tachyarrhythmias. Now, the symptoms of Wolff-Parkinson-White are actually the symptoms that one gets when they have the tachyarrhythmia. So it's the symptoms of AVRT, such as palpitations, collapse, chest pain, shock, shortness of breath. And as we've already covered, some of those you'd want to manage as adverse features and give shocks for. Others you'd want to just go down the normal pathway of vagal maneuvers, adenosine. If you identify that someone has Wolff-Parkinson-White, then you want to go for the radiofrequency ablation of that pathway, which has really, really good outcomes. And I've just included on the right here some of the key features of an ECG of someone with Wolff-Parkinson-White. And this was the ECG that you guys had before. So you can see here, we've got a very short PR interval, nice slurring of the QRS, seen nicely in V4 as well. The QRS complexes are slightly broadened, not quite 3 full squares maybe, but definitely more than 110 milliseconds. So you've got some really good features there of Wolff-Parkinson-White, and it can be quite subtle, and I would say it's definitely a good finals question to get tested on. So just a brief recap on AVRT. It's a paroxysmal supraventricular tachycardia. So the issue is arising somewhere above the level of the bundle of His, and it's due to an anatomical circuit that exists between atria and ventricles. We've said that an example of this would be the accessory pathway seen in Wolff-Parkinson-White. And essentially what happens is you get this re-entry circuit where the conduction just goes round in a circus rhythm via this accessory pathway. The initiation of it is usually due to a premature atrial or ventricular beat. And essentially the conduction can go either way. It can either go down the accessory pathway and then back up the intrinsic electrical structures, or the other way around. But the point is it sets up a circus rhythm. So that's the end of Wolff-Parkinson-White case. So I'm going to just give you guys just 1 minute just to take a quick breather before we get started on the final case, which is all about AV block and pacing. So case 3 of 3, we've got Mr. Villanueva, a 54-year-old man who presents to the emergency department with a fall. He describes a sensation of dizziness prior to falling and thinks he may have blacked out. He says this is the third time this has happened in a month. He has a background of ischemic heart disease. He's had PCI to his LAD in 2017, and he also has hypertension. His observations, he's a little bit bradycardic, on the lower side of normal blood pressure, and all other obs are normal. Whilst you're performing an ECG, you also load up the patient's notes on your computer, and an ECG from 2018 is on the system for comparison. The first question is, what abnormal finding is present on Mr. Villanueva's ECG from 2018? And the options are first degree AV block, left bundle branch block, Mobitz type 1 AV block, Mobitz type 2 AV block, or right bundle branch block. Here's the ECG. So which of the following is a correct description of this ECG from 2018, not Mr. Villanueva's current admission? The options: first degree AV block, left bundle branch block, Mobitz type 1 AV block, Mobitz type 2 AV block, the right bundle branch block. I'll leave the ECG up just for a little bit longer once you guys vote. Okay. So majority have gone for a left bundle branch block, and a couple of votes for Mobitz as well. So correct answer is, well done, it is a left bundle branch block. So we covered bundle branch block in quite a lot of detail in ECG part 3, if you want to check that out. But yeah, well done, that's fantastic. So, I mean, the main reasons, just quickly looking at this ECG. So first of all, broad QRS complexes, that's a key one for bundle branch block, because if you block one of your two sort of fascicles within the bundle of His, the left or the right bundle, then you're going to rely on the other bundle to get the electrical activity to both ventricles. And this kind of takes a little bit longer. It means your ventricles are going to be polarizing for longer as that wave moves down one of the bundles and then across to the other ventricle, which leads to a wide QRS complex. And the key here is this broad notched R wave in V6, which is classical of a left bundle branch. You also got a kind of deep slurred S wave in V1. Well done. The next question, what abnormal finding is present on his current ECG? All right, so current ECG, I'll pop that up in a second. Our options are first degree AV block, Wenckebach phenomenon, Mobitz type 1 AV block, Mobitz type 2 AV block, and a right bundle branch block. I'll just set the question up for you guys to vote on. And get the ECG shown. So here it is. This is his current ECG. I would particularly sort of encourage you guys to look at the rhythm strip. So let's see what you guys are voting. Fantastic. Yeah, majority rules once again. Mobitz type 2 AV block. Brilliant stuff. Yeah, fantastic. So let's have a little look at why that is the case. So looking at this ECG, particularly at the rhythm strip, you've got the PR interval. You've got a P followed by a QRS, a P followed by a QRS. There's no increasing in the PR interval, but then you've got a missed beat. So there's a P wave that doesn't conduct to give a QRS. Okay, and then it's back, and we've got a P to QRS, a P to QRS. These are the same intervals. If they were prolonging, you might think that that's a Mobitz type 1 or Wenke back. Both answers are kind of the same, so you could kind of rule that one out. But in Mobitz type 2, you get a P followed by a QRS, another P followed by a QRS, and at some point, you're going to get a sporadic block from P to QRS, leading to a missed ventricular beat. One of the key things that might help you identify a Mobitz type 2 block, and I mentioned this in part 3, is that it's often associated with left bundle branch block. So the fact that this patient had left bundle branch on both of these ECGs should really have started to make you think perhaps this will be a Mobitz type 2 question. So fantastic stuff, Mobitz type 2. We said it's a sporadic block of atrial impulses to the ventricles without progressive prolongation. If it did have progressive prolongation, that's Mobitz type 1. It's usually due to a structural issue in the His-Purkinje cells compared to a functional issue with the AV node in Mobitz type 1. And patients tend to have a left bundle branch block and possibly an element of right bundle block as well. There may be no pattern to it. So you may have a P wave that fails to conduct in a completely, a pattern that you can't make out, or it might be a fixed block. So for every 2 P waves that fire, you get 1 that doesn't. Or for every 3 P waves that fire, you get 1 that doesn't. And that's important to note, because the more times that your P wave fails to conduct, the worse that's going to be for the patient, because essentially that means the less ventricular depolarizations they're getting, and thus contractions, thus cardiac output. So you need to treat it seriously, Mobitz type 2, because it can lead to hemodynamic compromise and also progress to complete heart block. So anybody, including Mr. Villanueva, who comes in like this, you need to admit them, monitor them on a cardiac monitor, potentially offer temporary pacing, so pacing kind of on top of the chest, so like cutaneous pacing, and then eventually a permanent pacemaker. Some causes to think about, so an anterior MI. We noted in this case that Mr. Villanueva had PCI to his LAD, so it's quite possible that he's had some structural damage to the septum. And then we've got some slightly more common things like myocarditis and SLE, and there's also some common drugs that can cause this. But as I said, this was all covered in a lot more detail in part 3 of our ECG series. And we've covered briefly about how high-grade AV block is something to note. If your P waves are not conducting as often as you'd like, then that's more dangerous than someone who's, it's only every now and again that their P wave doesn't conduct. So on to the next question. We're almost home and dry now with about 15 minutes to go. Which of the following is not a possible management option for this patient's bradyarrhythmia? Now, options are adrenaline, aminophylline, atropine, dobutamine, or isoprenaline. Okay, let's see where the votes are. Okay. So the correct answer is dobutamine. All right, much outrage. So let's have a little look at what's going on here. So essentially, all of the drugs listed other than dobutamine are mentioned in the ALS bradyarrhythmia protocol. Okay, aminophylline would be a very rare drug to use, but it is listed, whereas dobutamine is not. It's a beta-1 agonist that's usually used in the kind of acute heart failure setting as an inotrope, not for its chronotropic benefits, really. And I'm just looking at this kind of protocol here. This is a kind of BiteMedicine amalgamation of the ALS algorithm. And if we look at these measures, we've got a gentleman who's come in, he doesn't have adverse features, so we go down this line, but he's got bradycardia. Is he at risk of asystole, of sort of flatlining? He's got Mobitz type 2, so yes. Now we're looking at what to give him. We look at our options here. Atropine, isoprenaline, adrenaline, aminophylline are all featured, though butamine is not. So a bit of a tricky one there, but hopefully one that you can take away and learn from. So which of the following would be the most appropriate device to insert for definitive management of Mobitz type 2 AV block? This is where we're getting into our pacing section. So single chamber pacemaker, dual chamber pacemaker, implantable cardioverter defibrillator, ICD, cardiac resynchronization therapy, CRT-D, or transcutaneous pacemaker. Which of the following would be the most appropriate device to insert for definitive management of Mobitz type 2 AV block? I recognize that there are some caveats to this question, and it's a case-by-case basis, but given Mr. Villanueva what he's got, what would be most appropriate? So majority here are going for a dual chamber pacemaker, and the majority this time are right. Well done, guys. Fantastic stuff. So let's have a little chat about pacing. So I'll leave these answers for you guys to look at in your own time. We may as well just talk about it now on this next slide. So what do we mean by the different terms? So single chamber simply means that you've got one lead that's connected to your little box, the generator, okay? And that lead goes from the generator into either the right ventricle or the right atrium. And it gets there by going down one of the veins, sort of axillary vein, into the superior vena cava, then it sits either in the right atrium or the right ventricle. In a dual chamber, it sits in both, so you've got two leads. In a biventricular pacemaker, okay, which does what it says on the tin, it's in the left and the right ventricle as well as the right atrium, so three leads. And you'll often see that referred to as a cardiac resynchronization therapy device, or CRT. Finally, the last point about cardiac devices is this ICD that you may hear talked about. ICD is not a pacemaker, okay? What it does is deliver a shock instead. So what's the function of a pacemaker? Well, essentially the two main things that it does is it paces and it senses. So pacing simply means it delivers a little depolarization to wherever the lead is placed, and that essentially takes over for a lack of a normal conduction system. But it also senses, so it can detect whether or not your atria or your ventricles have intrinsic electrical activity already going on. And based on whether or not they detect that, the pacemakers can sometimes choose whether or not to deliver that pacing depolarization. Okay, the pacing and sensing are two terms that are probably good to get your head around. And in terms of putting the device in, we've briefly touched on it. So the leads will go down the usually kind of axillary vein into the superior vena cava, into the heart chambers. The other ends of the leads then connected to that generator box, which is then inserted just under the skin and tends to be on the side of the body, which is your non-dominant hand. So if you write with your right hand, then you'd use your left, then they put it on the left side. So let's talk about indications of each type of pacemaker. So sorry, before we do, just want to briefly touch on the modes that you can set your pacemaker to have. We've sort of already touched upon pacing and sensing. So You'll sometimes hear this terminology on a cardiology ward, where someone will say, oh, this patient has a DDD pacemaker or a VVI. And what that essentially means is it tells you what the pacemaker is doing. So in a DDD, you've got both the atria and the ventricles being paced. So they have both, you've got a lead in both and could at any point deliver a depolarization to either. If it's DD, then you've also got both chambers being sensed. And if they're being sensed, looking for any intrinsic activity, based on whether there is any, it can either inhibit or trigger a pacing. Okay, so that's DDD. In VVI, that would usually be a single chamber pacemaker where you're pacing the ventricle only and detecting any intrinsic ventricular activity. If you do detect any, you might want to inhibit the pacing and allow the heart to do its natural thing. That would be a VVI. So this is kind of goes above and beyond the level of kind of medical school, but it's just something to be aware of what these terminologies mean, and you can always refer back to it if you ever end up with a cardiology job in your first few years as a doctor. But let's just work through each chamber or each device quickly in turn. So we've got our single chamber here. So you can see the generator box and a single lead that sits in the right ventricle. So that's how you know it's a single chamber pacemaker. It'll be either in the right atrium or the right ventricle. Now it's used in elderly people because it's quite a simple procedure to put in, or those with atrial fibrillation. Now the reason being is if your atria are doing their own thing and creating chaotic electrical activity, you're not going to want to know necessarily what is going on in there and kind of using that to conduct activity to the ventricles. You just instead can just put a VVI single chamber pacemaker and can just regularly cause that electrical contraction or electrical depolarization in the ventricles to occur, which will lead to regular contractions and a regular pulse, as opposed to some sort of irregular pulse. Common mode is VVI. The issue is that you lose that synchrony between your atria and your ventricles. So if they're not talking to each other, then your atria may be contracting blood into the ventricles at a time when the ventricles are perhaps contracting themselves. So what can actually happen is with a single chamber pacemaker, if not set exactly right, you can get reduced cardiac output, and that's something called pacemaker syndrome. Because essentially, your intervention of that pacemaker is reducing cardiac output because of that AV synchrony. So that's a kind of summary of single chambers. Dual chambers, all right, so it's on the opposite side this time, and you can see we've got two leads, one in the right atrium and one in the right ventricle. Example being a DDD moding, so it's pacing both right atrium and right ventricle. It senses in both and it can inhibit or trigger. It's deemed or it's thought to be physiologically superior because it's sort of clever enough to be able to say, right, well, give the pacing to the atria at this point, and then after a certain amount of delay that would mimic our normal AV delay, we can pace the ventricles, and you'll get that normal cardiac function of atria contracting and then ventricles contracting. But if you had AF, for example, you wouldn't want to be following what your atria are doing and getting that conducted to the ventricles. It is deemed a very reasonable option for someone with AV block, which is why the dual chamber was the chosen device for Mr. Villanueva. And then finally, we've got CRT or biventricular pacemakers. And here you guys should be able to see you've got three leads, right atrium, right ventricle, and also left ventricle. It is a technically more challenging procedure to insert this one. One of its big bonuses is that it assists with ventricular synchrony. So if you've got a bundle branch block and ventricles are receiving their electrical activity later and therefore are contracting out of time, then you can use a CRT to get them from going like this to suddenly beating together, which is obviously more optimal. You've got two different types. You've got the CRT-P, right, which is the pacemaker function only. And then you've also got the CRT-D, which comes with the pacemaker and also the ICD. And just a brief reminder, the ICD is that shocking device that you can put into someone that will deliver a shock. For example, if someone's regularly prone to having episodes of ventricular tachycardia or some other life-threatening arrhythmia, also you can be used for people with HOCM. So I hope that kind of is a demystifying terminology for pacemakers. And as I say, all of these slides are available on the website under the session for tonight. So please do go back through them if you didn't think quite understood everything, because it does take a bit of time to get your head around, but I actually think it's a really useful thing to know about. So one last question. So Mr. Villanueva is fitted with a dual chamber pacemaker, and after some follow-up is discharged from the cardiology outpatient team. 5 years later, he develops shortness of breath, peripheral edema, and is diagnosed with heart failure, NYHA 4. His ECG continues to show a paced rhythm with left bundle branch block and QRS duration of 160 milliseconds. So a broad QRS complex, left bundle branch block, and NYHA 4. Given his NYHA score and QRS duration, what device is indicated? So this was the top decile question for today. So options are CRT-D, CRT-P, ICD, continue with his DDD dual chamber pacemaker, or there is no clinical indication for a pacemaker. Give you a few more moments to vote. All right, let's see. So, majority thinks CRT-P, but we've got a couple of votes there for CRT-D. So you guys are thinking along the biventricular pacemaker line. Correct answer is CRT-P. Fantastic stuff. So let's return to the slides just to have a little look why. So working our way down, CRT-D is incorrect. RCTs have shown no benefit from the addition of an ICD as part of the kind of CRT pacemaker for any patient that's NYHA 4. Okay, so that's end-stage heart failure. We don't use ICDs, therefore CRT-D, because it's got ICD in it, is incorrect. CRT-P is correct because the patient has a broad QRS duration, and so that biventricular pacemaker will allow that ventricular synchrony to come back, which might promote some improvement in ejection fraction. ICD, we've already said, is wrong. Continuing with the DDD pacemaker would be wrong, and there is absolutely a clinical indication for a pacemaker, so the last one is wrong. And this is shown quite nicely. So this is essentially a carbon copy of that which is on NICE, which is indications for pacing and ICDs in patients that have both poor ejection fraction and left bundle branch block. So poor ejection fraction here is shown by how bad your heart failure is, so NYHA 1, 2, 3, and 4. And left bundle branch block is essentially shown here as how bad or how broad your QRS complexes are. And the last stage here is broad QRS plus a left bundle branch block. And what you should be able to see is that if you have NYHA 4, then it is never indicated to give an ICD. The RCTs don't support giving an ICD. But as you'll see along the bottom, anybody with a QRS more than 150 milliseconds, plus or minus left bundle branch, with some type of heart failure, has an indication for a CRT device, so biventricular pacing. And as you go from left to right, it becomes less appropriate to have that additional ICD function. So I wouldn't say you necessarily need to know this table inside out and back to front, but actually if you look at the NYHA 4 column, okay, and know that ICD is never given in end-stage heart failure. And if you also look down the left and you see that those with the broadest QRSs always need some sort of CRT, I think any question that you were given would probably test these sections here. So this far right column and this bottom row. And I think you could remember that quite easily. So that's the end. Thank you for sticking with me. I'm sorry we didn't manage to keep it exactly under an hour. I hope it was useful. That does mark the end of our ECG series. And we're happy to be contacted by you guys if you want us to do any other type of webinar series, particularly if it's an area that you struggle with. I know in the past we've done ABG interpretation, we've done imaging interpretation. So anything that you think will be useful, we'd be very happy to schedule for future.